Assalamu alaikum. Our lecture is testicular tumor. By the way, I hope that you all are well and keeping strictly adhere to the health measures and health advice by staying in home. And in addition to that, you have to encourage your family member to do the same. Now, starting with the lecture is the testicular tumor. First, we are starting with the percentages and figures. 1 to 2% of all malignant tumors, I mean the testicular tumors representing 1 to 2% of all malignant tumors in the body. It's most common malignancy in men between the age of 15 to 35 years of age group, and this is very important. It's most common malignancy in men at this age group, in the young age group. Benign lesions represent a greater percentage of cases in children than in adults. And there are 3 peaks of age group. The first peak is between the age of 2 to 4 years, and the second peak between 20 to 40 years of old. And the last one, the third peak, is above 60 years of old. Another fact, very important fact related to the testicular tumor is that it is one of the most curable solid neoplasm, and it representing a very good example of the success of the multimodal treatment of malignancy. Multimodal treatment, it means the combination of different strategy of treatment, which including the surgical treatment, chemotherapy, and radiotherapy. So this is the meaning of the multimodal treatment, and the testicular tumor have, by the introduction of this multimodal treatment, give very good prognosis and high cure rate of about 95%. Etiology and risk factor, including cryptorchidism or undescended testis, intersex disorder, testicular atrophy, especially in patients with male infertility, trauma, chromosomal abnormality, loss of chromosome number 13, number 11 or 18, and abnormal chromosome 12p, sex hormone fluctuation, and estrogen administration during the pregnancy. Classification. We can in general classify the testicular tumor into a primary, secondary, and paratesticular tumors. Primary neoplasm of the testis can further be subdivided into germ cell tumors and non-germ cell tumors. You know, the testis containing germ cells, and if the tumor arises from the germ cells, we call it germ cell tumors, and if it arises within the testis from other cells other than the germ cells, we call it non-germ cell tumors. And the germ cell tumors further can be subdivided into seminomatous germ cell tumors and non-seminomatous germ cell tumors. This is whole of the primary neoplasm of the testis. And then the second part of the classification is the secondary neoplasm. It means that the tumors arises primarily anywhere from the body and then metastasize into the testicles. We call it secondary neoplasm or paratesticular tumors. Types of testicular cancer. Germinal tumors. Over 90% of all cancers of the testis are germinal, and these may be further classified as seminomatous germ cell tumors or non-seminomatous germ cell tumors, and this based on the histopathology. Seminoma develop from sperm-producing cells of the testis and tend to be localized, whereas non-seminomatous germ cell tumors grow more quickly and tend to be metastasized earlier than seminomatous germ cell tumors. Non-germ cell tumors, testicular cancer, may also develop in the supportive and hormone-producing tissues or stroma of the testicles. The two main types of stromal tumors are Leydig cell tumors and Sertoli cell tumors. These tumors infrequently spread beyond the testicle, However, there is a small number of them can metastasize and tend to be resistant to chemotherapy and radiotherapy. Secondary testicular tumors. These tumors have metastasized to the testicle, as I said, from other organs. Lymphoma and leukemia is the most common, and the prognosis depends on the cancer itself, the primary lesion, and the treatment depends on the specific type of cancer. The other slide is the lymphatic drainage. The primary drainage of the right testis is within the interaortocaval region. Left testis drainage, the para-aortic region in the compartment bounded by the left ureter, the left renal vein, and the aorta, and the region of inferior mesenteric artery. A crossover from right to left is possible. Clinical features most common is painless swelling of one testis, dull aching pain or heaviness in the lower abdomen, 10% acute scrotal pain, 10% to present with metastasis. Other rare presentation, there might be neck mass, cough, anorexia, vomiting, backache, lower limb swelling. All of these are due to the metastasis. And gynecomastia and infertility also might be one of a presentation of testicular tumor. But the most common is painless swelling of one testis, which is discovered accidentally by the patients or sometimes accidentally by examination by those who are working in the medical institutes. A clinical manifestation, a mass or lump in the testis and generally painless, enlargement of the testis, possible heaviness in the scrotum, inguinal area or lower abdomen, backache from the retroperitoneal lymph node, abdominal pain, weight loss, and general weakness due to metastasis. Enlargement of the testis without pain is a significant diagnostic finding. Testicular tumors tend to metastasize early, spreading to the lymph node in the retroperitoneum and to the lungs. Physical examination. All patients with a solid, firm intratesticular mass that cannot be transilluminated should be regarded as malignant tumor unless it proves otherwise. Firm to hard fixed area within the tunica albuginea is very suspicious. Always examine the contralateral normal testis. Differential diagnosis, testicular torsion. The clue for the differentiation is that testicular torsion is painful. Epididymoorchitis or epididymitis, it's painful also. Hydrocele cystic mass, and it's not solid. Hernia cannot get above it. Hematoma, history of trauma. Spermatocele outside the testicles, and syphilitic goma, which is very rarely to be seen nowadays. Scrotal ultrasound. Ultrasound of the scrotum is basically an extension of the physical examination, and it is essential in the diagnosis, and you have to send every patient with testicular tumor suspicion for ultrasound. It will be representing a hypoechoic area within the tunica albuginea, is markedly suspicious for a testicular cancer within the tunica albuginea. Sometimes the tumor might extend into the tunica albuginea according to the stage of the tumor. So hypodense or hypoechoic area, by ultrasound we can classify the density into hypodense, isodense, or hyperdense, or hypoechoic, or neutral echoic, or hyperechoic. Most of the testicular tumors by ultrasound presented as a hypoechoic area. Tumor markers is very important. It's usually elevated in non-seminomatous germ cell tumors. Two main classes. oncofetal substance, alpha-fetoprotein and HCG, and cellular enzyme. The most important is the alpha-fetoprotein and HCG. Role of tumor markers, it helps in the diagnosis if positive, and after orchiectomy, if markers are still elevated, it means that there might be a residual disease, and it's very important as a diagnostic tool and as a prognostic tool. But the absence of the tumor's markers doesn't exclude the presence of tumor, as if you know, some of the testicular tumors secreting these markers and others is not. But if it is secreting, it's very important for the diagnosis and then for the prognosis. When you remove the tumor surgically and the tumor markers subside its level to zero, it means that the patient there is no residual tumor of the in the body. While if it is remain, it means that there might be a residual tumor. Imaging study including chest X-ray for the lung metastasis and CT scan for lymph node metastasis, and this is very important for staging of the disease, for staging of the malignancy. Treatment is a multimodal therapy, surgical, radical orchiectomy, and sometimes retroperitoneal lymphadenectomy is needed in high-stage disease, chemotherapy, and radiotherapy. So the treatment for testicular neoplasm need multimodal therapy, and it representing, as I said at the start of the lecture, is a very good example of the response for such multimodal therapy, and the prognosis is very good, especially if the patient presented at early stage of the disease. Medical management. The goals of management are to eradicate the disease and achieve a cure. The testis is removed through an inguinal incision with a high ligation of the spermatic cord. This is what we call it radical orchiectomy, and it is different from simple scrotal orchiectomy. We have to remove the whole of the testis and the whole of the spermatic cord into the deep inguinal ring. The patient may develop ejaculatory dysfunction with resultant infertility. Thus, sperm banking before surgery may be considered. Indeed, ejaculatory dysfunction, especially if the patient have retroperitoneal lymph node dissection, what we call it rippling, because this will affecting the nerve supply into the muscles which is responsible for the ejaculation, and the patient presented with retrograde ejaculation. And in addition to that, any patients with confirmed diagnosis of testicular tumor before doing surgery, before doing or sending for chemotherapy or radiotherapy, we have to do sperm banking, even if the patient is still unmarried, because the other line of a treatment that the patient will do during the process for curing of his disease will affecting his fertility potential. It affecting by the chemotherapy and by the radiotherapy, or by the surgery, as we said, by the retroperitoneal lymph node, which affecting the nerve supply into the process of ejaculation. So the patient should have a sperm banking to be used in the future for fathering a child by intracytoplasmic sperm injection. Post-operative irradiation of the lymph node is used in treating seminomas. Radiation is delivered only to the affected site and is indicated in situations where the disease does not respond to chemotherapy or for whom lymph node surgery is not recommended. Testicular carcinomas are highly responsive to chemotherapy. combining different types of treatment, including surgery, radiation therapy, and chemotherapy. Nursing management, assessment of the patient's physical and psychological status, it's very important. Monitoring for response to and possible effect of surgery, chemotherapy, and radiation therapy. Issues related to body image and sexuality is very important and we have to be addressed. Teaching the patient that radiation therapy will not necessarily prevent him from fathering a child, nor does unilateral excision of testes necessarily decrease virility. Reminding the patient about the importance of performing testicular self-examination and keeping follow-up appointment with the physician to examine the other testes for the possible arising of other tumors, so that it has to be catched at early stage for appropriate treatment.